Assalamu alaikum. I'm Dr. Mahbub Alam, Professor and Head of the Department of ENT of Ad-Din Medical College. Due to the coronavirus problem, my dear student, I am going to give lecture on online. May Allah save all of us from coronavirus. And today my topic is otitis media with effusion. Assalamu alaikum. Today my topic is secretory otitis media. There are many synonyms which are usually asked in the Viva. Synonyms are the guttural otitis media, serous otitis media, mucinous otitis media, glue ear. Definition of the otitis media with effusion: this is the chronic accumulation of the mucus within the middle ear and sometimes the mastoid ear cell system. And etiology of the otitis media with effusion is not exactly known, but several factors may be responsible for it, and various factors lead to the hyperventilation of the middle ear and transition of the fluid. In case of children, the eustachian tube dysfunction due to the damage to the eustachian tube epithelium by the viral diseases, as for example upper respiratory infection by the viral virus, and the craniofacial abnormality, that is the cleft palate. Then secondary to the chronic nasopharyngeal infection, that is the adenoid. Secondary to the allergy, and children with Down or Turner syndrome and gastro-oesophageal reflux play a role, and unresolved acute otitis media, which is also responsible for the otitis media effusion, where the infection is inactivated but resolution is not complete, so there is a sterile fluid is present. In case of adult, the chronic rhinosinusitis, allergy, nasopharyngeal carcinoma, radiation, barotrauma, gastro-oesophageal reflux disease, and poorly pneumatized mastoid. And here is the pathophysiology. Etiopathogenesis of the otitis media effusion: when there is acute tubal blockage is due to the absorption of the middle ear gases due to the various factors what we are already mentioned. There will be absorption of the middle ear gases, negative pressure will be developed in middle ear cavity, then retraction of the tympanic membrane, then translation of the middle ear cavity, and there will be development of the otitis media effusion. Clinical feature: it is seen commonly in children more between the 2 to 5 years and is often detected during the deafness-screening of the school children. And first of all, an infant's parents will give a history of the hearing impairment and otalgia, recurrent upper respiratory infection, mouth breathing, snoring, nasal obstruction, nasal discharge, and tinnitus. In long-standing persistent cases, there may be defect in language development and speech in children. And what will be the sign? Otoscopy reveals the tympanic membrane is intact but dull, lustreless and retracted. And sign of retraction are short or lateral process of the malleus is prominent, will be prominent. Handle of the malleus is foreshortened and more horizontal. Cone of the light is distorted. And color of the tympanic membrane is usually pale yellow, sometimes slight gray, or even blue, or just clear. And fluid level or air bubble is often seen. And few congested blood vessels may run behind the handle of the malleus, and sometimes there is fullness of the posterior segment of the drum. And this picture we have seen the air bubbles is seen in the tympanic membrane on otoscopic finding in otitis media with effusion. Here is the air fluid level is seen in this picture. Then there is otitis with effusion and malleus handle is slightly retracted. Malleus handle is slightly retracted. Then this picture, malleus handle is markedly retracted in otitis media with effusion. And there is the tympanic membrane in otitis media effusion showing the yellowish color. And this here is the otitis media effusion in the left tympanic membrane. There is a color is the blue color. And here the left tympanic membrane in otitis media effusion showing the clear color. And tuning for test show the conductive deafness, the Rennes test negative, Weber test lateralized to the diseased ear, and absolute bone conduction test is equal. And sequelae, in long-standing untreated cases, there may be atelectasis, retraction pocket, cholesterol granuloma, tympanosclerosis, or even cholesteatoma formation. And investigation is a pure tone audiometry confirms the conductive deafness, usually 20 to 40 decibel. Loss rarely exceeds 40 decibel. Tympanometry shows the flat type of the curve type B, which is confirmatory, and excess of nasopharyngeal lateral view to see adenoid. And here is the conductive deafness in pure tone audiometry, mild type of conductive deafness which is sloping to the right. And here is the impedance audiometry which is type B, flat curve, which is the confirmatory. And this is the way we can diagnose that. Number one is the clinical feature. Tuning fork test shows the conductive deafness. Pure tone audiometry confirms the conductive deafness, and tympanometry shows the flat type of the curve type B, which is confirmatory. The treatment will be, the number one is the profile is on inattentive and dull children should be investigated for middle ear, effusion and deafness. Sniffing having should be stopped. Underlying symptoms should be controlled, and large adenoid may require removal. Immunological disorder, if any, is to be corrected. Curative treatment is the first, the counseling and hearing tactics, but in case in undergraduate is not necessarily. But conservative management is sometimes helpful. The conservative management is aims at drainage of the effusion through the eustachian tube by number one, nasal decongestant drop, xylometazoline or oxymetazoline. Xylometazoline is 0.05% antazole or rhinazole, or oxymetazoline is 0.025% in case of adult, 0.05% in case of adult, 0.025% in case of children. It can be used for 7 days or up to 10 days. And nasal topical steroid numometazone furoate, or which a commercial name is Momesol or Amson, nasal spray, which 1 prop per nostril once daily for 1 month. Then the antihistamine tablet, where the allergy appears to play a part. We can use the antihistamine syrup, Allerges, histacin or Histalex, 1 teaspoonful 3 times daily for 7 days. And if we can use, we can also use the fexofenadine, 1 teaspoonful twice daily BD for 15 days. And antibiotic can be used in case of upper respiratory infection, unresolved acute otitis media, syrup amoxicillin and clavulanic acid, or tablet amoxicillin and clavulanic acid 375 mg 8 hourly for 7 days. If inflation of the middle ear is carried out by the Valsalva maneuver or the eustachian tube catheterization, or the child was instructed to chew the chewing gum. And last of all, we can be used also the mucolytic as carboxymethylcysteine. And if the otitis media diffusion cannot be cured by conservative management up to 3 months, then we are going to do the surgery in majority of the persistent cases, laryngotomy with the suction and clearance, under operating microscope under GA, in case of children if the fluid is thin, and laryngotomy with the grumete insertion if the fluid is glue-like, and laryngotomy with grumete, and adenotomy if the patient has also adenoid. To aspirate the thick mucus, 2 incisions may be required in tympanic membrane. One is the radial incision, and another is the carbonineal incision. Both is given for the ventilation tube insertion, with or without ventilation tube insertion. And then here is the grumete, and it is placed in the tympanic membrane, anterior inferior position. And we can use the hearing aid if it is the persistent OME, and to avoid the repeated surgery, bone conduction hearing aid we can be used, soft band bone conduction aid in a headband. This is all. Thanks for patient hearing. Assalamu alaikum.